You are listening to Perimenopause Explained. This show is about perimenopause, the years before menopause, when things start changing, also before anyone calls it menopause.
Each episode is real talk from real questions to explain what's going on in your body. No hype, no minimizing, just straight answers and honest conversation.
If something feels off and you haven't gotten clear explanations yet,
This podcast is for you. Hello, I'm Stephen Youngblood. This is Perimenopause Explained. I'm a physician, and this is Crystal Burke.
Hi, I'm Crystal Burke. I am a nurse practitioner, menopause specialist, and co-founder of the Menopause Clinic.
Quick reminder, we are offering general advice and not actual medical advice. This is just answering questions and talking about perimenopause and menopause from a broad perspective.
So today we're going to be talking about libido. What changes, what's actually happening, and what helps.
There we go. So let's start off with the patient. What do you say, Kristen?
Sure.
All right. So we have a 41-year-old woman, obviously. Her libido has disappeared. She loves her partner, but feels completely uninterested in sex. She goes to her physician, primary care physician or OB-GYN. They check labs and said everything is normal.
Yeah.
Tell me what's really going on with her.
So low libido is one of the most common things to happen in perimenopause, which is why we're talking about it today. So yeah, we see this very frequently in clinic. So yeah, labs are normal. The thing is first of all, it's important for her to talk about. Women rarely talk about it. A lot of women feel like talking about libido is extra, but it's not. If it's important to you, it's important. And sexual health is health. So in a 41-year-old woman, whether she's her periods are still the same, whether that's still the same, or she's had changes to her period, or any of those things, you can still have low libido before periods change. But estrogen's still changing. Testosterone starts dropping in your 30s. There's a lot of things that can happen. And so low libido is one of the most common things that we see. And that's the right age range.
So tell me a little more about we know the hormones are declining at various intervals.
Mm-hmm.
And in case of estrogen, maybe going a little bit just haywire in general. But how does that physically change a woman to make sex or decrease libido, make sex less pleasurable or decrease?
So one of the things we talked about last time was sex can become painful. So when estrogen declines, vaginal tissue changes. So it becomes thinner, drier. Sex can be really painful. So when that happens, your brain starts to think differently about sex. Sometimes it's just something you wonder about. Sometimes it's something you notice. It doesn't happen to everyone, but it is very common for sex to become painful. Also, estrogen has to do with desire. So the thinking about sex can be less. Testosterone starts declining in her 30s, so at 41, it does make sense that she would start to feel this because testosterone affects desire also. So one of the things I realized, and if you remember, we were talking to this guy once, and we didn't realize he was a sex therapist, remember?
Mm-hmm.
But we were just talking about things, and I realized that I hadn't had a sexual fantasy in a long time. But not even just that. I also realized I hadn't had a fantasy about or a daydream about anything in a long time. I used to have an imagination about everything.
Right.
And then remember we were having that conversation. I was like, no, I haven't had anything, any daydreams or fantasies in a while. That's actually really common in perimenopause. Sometimes women will realize it. Sometimes it'll be a year after and they'll realize, you know what? My thinking is different. My thinking has changed. I just don't think about it anymore. Have you heard of the grandmother theory?
I have not. I'm excited. Tell me about it.
So it's the evolution, we've talked about this, the change in evolution that a long time ago, women, after whatever age it was, whatever age they picked, when you got closer to not being able to have children, it became beneficial for society for women to not want sex.
So they could continue to live and
Raise the children.
And also be a source of information that gets passed on from generation to generation, right? So, and I didn't realize it was called the grandmother theory. So the theory would be that, you know, a woman in, I don't want to say prehistoric times, but let's say around 500 AD.
Yeah.
During the times of the Black Peds, medieval times, right?
Yes.
She's had her number of children. She's no longer sexually active. She can no longer have children, but she's raised those children, but she's now going to raise, likely to some degree, the next generation, because childbirth is dangerous.
Mm-hmm.
Even in today's society, childbirth is dangerous, right? Back then it was a lot more dangerous.
Mm-hmm.
And so it wasn't uncommon for women to die. And then that child gets raised by the grandmother.
Mm-hmm.
Plus, then you have a source of information.
Right.
You know, they become a midwife, they become various other aspects in the community.
Mm-hmm. Reproductive age women focus on reproduction and
if you graduate, if you survive, you become the matriarch, informational storage for that society.
Right. And so at that time, not wanting sex was beneficial.
Right.
But
it's a different time,
right? It's a different time. We've outlived that. And it doesn't, even if that's true, even if that is a part of how we're wired, it doesn't have to be it. There are definitely ways to treat low libido and to fix things. But yes, low libido is common because our hormones are changing. Both estrogen and testosterone are important in libido. And with the changes that we know happens, this is a physiological reason. Yeah.
Yeah,
it's coming.
It's interesting because the reality of it is our society has changed much faster than humans have changed evolutionary, right?
Yes.
Which is why we have issues with hypertension and diabetes, which really didn't happen back then because you didn't have to worry about overeating. There wasn't enough food to overeat, right? You were happy to get one square a day.
Yeah.
Right. 100%.
But going back to the 41-year-old woman, a lot of times she wonders, you know, like she starts to feel, not everybody, because everyone is so different in how they handle everything, but she's not sure what's happening. Maybe she knows this happens. Maybe she doesn't. Maybe she's talked to her friends. Maybe she hasn't. Maybe she has a great relationship, and she has a great relationship. She loves her partner, and it's nothing to do with that. But then after, it might go on for a while, and then she starts to think, is it me? Is something wrong with me? Is something wrong with us? It starts to second guess all of these things, but there's a reason that she does that, because we don't talk about it enough. But if she would only to know that there is a physiological reason and a way to fix it.
Right. And, you know, and again, we have a tendency, and I know we've talked about this before, we have a tendency to blame a lot of these things on raising kids, life, busy.
And that does have an effect.
And it does have an effect. Absolutely. Okay. Can we talk a little bit about arousal physiology?
Yeah.
Yeah. So kind of give us a 30,000 foot view of that, like, so people can kind of understand how it all plays out. So
the two parts of sex in general, right, are desire, which the thinking, the daydream, and the fantasies, the arousal, how the body responds. So in perimenopause and onto menopause, it can take longer for the body to respond, right? So if you have vaginal dryness, which it just takes longer for the body to respond. Sensation is different. When we lose estrogen, it affects sensation. So it can take longer. And some people can't have orgasms anymore, or it can take longer, or they're just weaker. I mean, it affects everything, but the body arousal definitely changes as a part of genitourinary syndrome of menopause.
Right.
It's a big long name, but that can absolutely affect arousal. And it can be hard for a woman who doesn't know that this is going to happen, because she blames herself, but that's her body responding to decreasing estrogen.
So a little bit about the genitourinary syndrome.
Genitourinary
syndrome. I know that one of the key elements is the pH of the vagina changes, right? So if we replace estrogen, does that pH, does, for lack of a better term, vaginal health come back around?
So yes, because all of these things happen because we're losing estrogen, but the pH of the vagina changes. So some people will get UTIs more frequently, especially after sex. So that's one thing. But it changes, losing estrogen changes the whole structure of the vagina. The vagina changes. So all of that, replacing estrogen with vaginal estrogen, yes, all of that can go back. It can reverse all of the changes, but it has to, you have to keep doing it. Once you stop using that vaginal estrogen, it happens again for most women. And one of the things to know, and a lot of women don't know this, is that if you're on systemic estrogen, so the whole body estrogen, so the patch and the gel, if you're on those, about 60% of women still will need vaginal estrogen.
60%, more than half.
More than half.
More than half.
And a part of my, that's what the literature says, that's what research says, and that's what I've seen really, but not everybody will have symptoms of genitourinary syndrome of menopause. Not everybody, but most will. So I think it's mostly the ones that have the symptoms that will need the vaginal estrogen still.
Gotcha.
Yeah.
So when you're prescribing estrogen for a woman, you could be in following this theory, giving two types of estrogen, right?
Yep.
A more systemic and then a local.
Definitely.
And so I would imagine that goes through insurances easily.
So insurance usually doesn't have a problem with this. Sometimes pharmacists do. Most of the time they don't, because pharmacologically it's very different.
Right.
Estrogen goes through the whole body. Vaginal estrogen does not. It stays in the vaginal and urinary system. Very rarely, but recently it has started to happen more where a pharmacist will question if a woman needs both. But yes, that they are very different, and many, many women need both.
And I can see how, like, if you are not knowledgeable in the field, right? You would say, well, why would you do both? That doesn't make sense.
Yeah.
But there's a lot of things in medicine that don't always make sense until after the fact.
Well, it just needs an explanation. It absolutely makes sense. But just like anything, you should know what the medicine is doing, what it's for, how it works. Yeah. And one of the questions somebody asked me the other day about vaginal estrogen is, do I recommend it to everyone for preventative reasons? And my answer is no. Medical guidelines say don't say that, but my opinion is yes, everybody should need it.
Everyone should get it.
Everyone should get it.
Every woman should get it.
Every woman should get it.
Every woman should get it. Right,
Yes.
right. Not everyone. Every woman. Absolutely.
Every woman.
So let's transition a little bit, because I think we've kind of talked quite a bit about the physiology. Let's talk about how this presents in the clinic, what we would see. So, you may have, so if we say we take the same woman, she's 41, she comes to the clinic, and, I would imagine that first visit with a woman talking about this can get emotional and long.
Sometimes not always, but sometimes, because the thing is this is all, I mean, sex isn't something you talk to a lot of people about. You might talk to your friends, but very rarely you're going to talk to someone that you've never talked to before.
Right. I could probably count, definitely on two hands, probably one, how many times someone's come into my office. And I practiced many years before, ground level practice, 15, almost 20 years. It doesn't happen very often.
Yeah. And no one has ever asked me about sex. No one. But
not as a primary care.
We're talking about talking about a healthcare provider. No healthcare provider has ever asked me about sex.
Right.
Right. So I ask everyone. On a first visit, I ask every patient, is this something that bothers you? Is it happening? Does it bother you?
Mm-hmm.
Because it could be happening and it might not bother you, and that's okay. But if it's bothering you, we need to treat it. We need to fix it. We need to talk about it and figure out what to do. But yeah, it's something that frequently comes up, and I'm going to say it's got to be more than half of the women I see that, yeah, it's happening and it's bothersome.
Yeah, I imagine so. Okay, so back to the clinic. Woman comes in. So tell me what you've seen this. What does it look like? Like, walk me through the kind of a conversation you would have with a 41-year-old woman who's going through this.
So first, the thing is to think about, how long has it been happening? Are there other factors involved? Because libido, desire, all of that is not just hormones. Hormones can bring you to the table, but it doesn't do the whole job. So there's the physical, so hormones, desire, arousal, psychological. Because one of the things is, if you've had painless sex before, even once, it can rewire your brain and it can be difficult. So, and there's lots of things in the brain that can happen around sex. Then there's social things. How's your relationship? Mm-hmm. Are you working a full-time job with 3 kids and one sick, and you're taking care of your parents, and there's a lot of things involved in all that. So we go over that, right? Like what's all involved in that. And then we talk about desire and arousal and how hormones affect that, how the body changes, things to do about it, right? So estrogen and testosterone both have a lot to do with all that. We talk about why it's happening, like the physical changes to the vagina, the changes to the brain, like we just talked about. We talk about all of that. And most women want to be treated for that. And it's not always going to be the first thing, right? Because in perimenopause, there's so many things. Sometimes it is the first thing, and that's okay. But a lot of times it might be, let me fix my mood so I can keep my job. Right, but libido is important to me, and I want to get to that next. Whatever it is, if it's important at all, it can be treated. Yeah.
Okay. So let's flip over. Like, what are some of the treatment options for libido? Like, obviously hormone replacement, mm-hmm. but anything in addition to that? Like, what are the things? Like, can we consider pelvic floor therapy?
Yep.
Or, can you go into a little bit more about that?
Yep. So definitely pelvic floor therapy. Pelvic floor therapy has a lot to do with sensation. Like, the pelvic floor can affect so many things involved in sex that, yes, pelvic floor therapy is really important for a lot of women. But I think that the women that do best are going to do best with hormones, pelvic floor therapy, stress management, all of the things, making sure relationship is good. All of those things that's going to be what's important to make sure it's as good as it can be.
Okay.
Yes.
Let's go a little bit more into, like, what are some, like, what would be like a standard, at a very broad level, hormone replacement look like for someone who's going through this? Like, maybe the first step.
So for the most part, not everybody, because everyone is so different. I have people that start on testosterone first. I have people that start on estrogen first. But most women, by the time I see them, if they're having vaginal dryness, that means low estrogen. Mm-hmm. So most women will need estrogen and progesterone if they have a uterus. I mean, this is the thing. This is so individualized. That's hard to say. But we look at what's going on with them, and it's going to be estrogen and or progesterone and testosterone for the most part. But everyone's so different. So the order can change. The specifics can change.
Okay. So some additional other questions. Why does orgasms take longer during perimenopause? Like, is there a physiology behind that?
Yes, yes. Because so the loss of estrogen changes the vaginal tissue, makes it thinner, it affects the nerves, sensation is less. All of those things make arousal harder.
Okay. Why do women feel emotionally disconnected during this time period?
So I had one patient that explained it to me this way. And in all honesty, I knew what she meant, but I didn't think about it this way. She said, it's like he's touching my arm, just like this, when she was having sex.
Okay, so it wasn't like a good feeling.
It when you have no sensation,
Mm-hmm.
it doesn't feel like it used to. It doesn't feel like you think it should. And it doesn't feel it. I mean, the thing is if it doesn't feel like it used to, you wonder what's wrong with you. And so, or she was, and I get that, and there's nothing wrong with her, but that's what happens.
Gotcha. Why does sex suddenly hurt?
Because as we lose estrogen, the vaginal tissues get thinner, and so it's common for that to be painful.
And why does the libido come and go?
So in perimenopause, your estrogen's fluctuating. It's all over the place. It's a hormonal roller coaster. So your symptoms will come and go with that. When estrogen's high, you'll feel one way. When estrogen's low, you'll feel another. So that's the point of HRT in general, right? Like when we're giving estrogen back in perimenopause, it's to if say your estrogen is here, we're going from here to here. The idea is to give estrogen to bring it up so the swings aren't so wide and you're not having low estrogen.
Okay. So and that swing, that can happen within a day. This happens over weeks.
It can happen within a day. It can happen. But for some people, they'll notice, you know what, this week I have this symptom, next week I don't. But research shows it can happen in a day. Yeah.
Okay. All right. Do you have any takeaways you want to bring?
Just that one of the things to know is that if you're having a libido, it doesn't mean there's anything wrong with you or your relationship. If there is a physiological problem and ways to fix it.
Okay. All right. Excellent.
You are listening to Perimenopause Explained.